that Eleanor Vigilante is here to talk to us. And also, this is being recorded, if that wasn't completely obvious. And Eleanor can tell you more about that. But Eleanor and I actually worked at Sequoia Hospital together, and she's been the ER director there for about 4 years. She's a nurse and worked in New Jersey for a hospital back there, including in an ER, for about 10 years, and she can tell you more about her background, but I just want to thank her very much for being here. And she's going to talk a little bit and then really make time for your questions. So you all submitted questions. Hopefully you have those, and you can just fire away when it's time. So Eleanor, come on up.
As April was explaining, I am an ER nurse by background, and essentially I spent my first year in a medical surgical unit, which is not uncommon for nurses. It's actually a really good background. They want you to do that because you sort of see a little of everything, and you get a real feel for how to handle patient care and things like that. And then I was lucky enough about a year later to go into the emergency room. I worked in a pretty busy emergency room, although I did not work in a trauma center. So, and I think one of the questions might have been sort of what's the difference between an emergency room and a trauma center. And so I'll just answer that one now since kind of went on there. Basically, an emergency room, there's a couple of different levels of emergency rooms. Some are like basic medical care, meaning that you have a physician on staff 24 hours a day, you have nursing care, and you have some or most services available, specialty services like orthopedic, plastic surgery, general surgery, things like that. A trauma center means that if there were an accident on the 101 and there were injuries, that those people would be taken to that trauma center. So things like if you fall from greater than 13 feet, it's considered a trauma. So there's like some criteria is like when you go to the trauma center. It's not always crystal clear, but we have some basic criteria, and that's where you would be transported to in the ambulance. However, doesn't mean people can't just walk into an ER, any old ER, and have a traumatic injury. And that does happen somewhat regularly. People kind of don't realize they fall off of the roof of their house. They're still conscious. They get their friend to drive them in, and the next thing you know, they have pelvic fractures and liver lacerations and all these horrible things, and then you transfer them out because we don't have those kind of trauma services there. What a trauma center has basically is 24-hour trauma surgeon coverage, certain neurosurgical coverages, and there's different levels of trauma centers, but I'm not going to get into all the details of all the different levels, but that's just kind of an idea of the difference between basic emergency and trauma center. So I worked in a pretty busy ER. We saw about 120 patients a day, and we had 35 beds total when we were at capacity, and about 10 hallway beds that we call it. So pretty much that's the lingo. You know, they say, oh, how many beds do you have? Well, we have 15, but we have 5 hallway beds. Almost every emergency room in the United States ends up just being overcrowded, as you saw in that movie, and just sticking people in the hallway. A lot of people see patients actually out in the waiting room. Some places, what they call it the chairs, they'll just, they just have this section set up of chairs that, that's where like minor injuries and stuff, they'll coughs, colds, they'll see them out there. You never even get into the main ER, and they kind of treat you there. So my ER was like that. We had chairs, we had a fast track, we only got like walk-in traumas. We were off of actually Route 80, so we got a fair amount of car accidents and a couple of drug busts here and there because that's where they were running drugs from Pennsylvania to New York City. So there was some fun stuff in there, and I learned a lot. And then I got into some quality and patient safety later on as I was no longer at the bedside, and into risk management. And that's actually a really interesting role in healthcare, risk management. It's, you deal with lawsuits, you deal with really unhappy people, you deal with some really serious stuff, and then you deal with somebody that's upset because the ER cut their nightgown off during CPR and they would like to be reimbursed for that. So you kind of have this really long, thing. You're like, really? Oh, we weren't thinking of that when you were dead, but hey, no problem, we'll reimburse you for that. So you kind of get some really interesting stuff. So I did that for a while, and then the opportunity came up at Sequoia to be the emergency room director, and having done some management in emergency rooms before, I thought this is cool. I wanted to get back to my roots in emergency medicine. So I kind of wanted to say a little bit of what makes healthcare change, the business of healthcare. Of course, there's all kinds of innovation and really cool stuff going on for the medicine side of emergency medicine or the medicine side of general medicine, but really why does the business of healthcare change? And there's kind of three things that make us change: innovation, regulation, and compensation. So innovation means, some really great technology comes out. Like, for instance, the robotic surgery that really started to get popular about 10 years ago, and you were really on the cutting edge if you had that. And so hospitals had to start thinking about, okay, we want to attract clients, right? I mean, we're trying to, even when we're not for profit, we're trying to make money. We want to keep our doors open. So, and the for-profits, of course, you're like, well, how are we going to spend $1 million to get this robot? And how are we going to attract new surgeons? Well, we have to get the robot. And so innovation sort of forces us to change. And then compensation, that's definitely a huge part of why we change. So things like all these fancy terms like DRGs, the new CMS 2 midnight rule, observation versus inpatient. It really makes us change the way we do business, because you're just not going to get compensated anymore, or you'll get compensated less. So just, interesting, I noticed April put up here like social admissions. We do a lot less of those now because we get no money for them. So we really work hard to get the patients home, which is really where they should be, right? I mean, you're in a hospital, you have a chance of getting more sick than you already are. And so if you're really not sick and you don't need to be there, we probably want to get you out. So that compensation, which is usually driven by CMS, the Centers for Medicare Medicaid Services, which is basically the federal government that pays us for Medicare and Medicaid patients, they usually are the driving force of a lot of these regulations and these compensations that we're getting. And then other Blue Cross, Blue Shield will get on board as well. Sometimes the reverse happens, but usually the bigger companies kind of make enough money and they're happy. But when they see the federal government sort of mandating something, they're like, oh, this will work. Yeah, we can get on board with that too, because it's much easier to push it from the federal government. So that's compensation. And then the last area that sort of forces us to change is regulation, and which we are regulated to death. So there's a lot of really great regulations that come out, and then there's a lot of things that you just think, wow, who came up with this and how are we going to comply? So the biggest one I would say that probably changed emergency medicine would be EMTALA, which is the Emergency Medical Treatment and Labor Act. And that actually was already enacted when I got into emergency medicine, and enacted in 1986. And I'm not going to read the boring law to you, but I wanted to at least give you the basic quote of it, which is basically saying, the hospital must provide for an appropriate medical screening examination within the capability of the hospital emergency department to any individual who comes to the emergency department and requests examination or treatment. And the purpose of this screening examination is to determine whether or not an emergency medical condition exists. So basically, that really changed the face of how emergency medicine handled people coming in. So in the past, prior to this law, they could deny you services, essentially. Even though when you think about what an emergency room is today, you would never imagine really necessarily being denied at least a basic service, at least a medical screening. But that wasn't the case. So you came in, you had very complicated illness, you didn't have insurance. Well, we don't want to admit you because we know you're probably going to be here for 10 or 15 days. We don't want to absorb that huge cost. So let's see if we can ship you someplace else. And there was a lot of that patient dumping going on. And that's why a lot of times EMTALA is dubbed the anti-dumping regulation. It's really just not to dump uninsured or underinsured patients somewhere else. And the Labor Act part of it covers laboring moms. So you can't just transfer somebody in labor who doesn't have insurance because now you have two patients, and it's a really, really different way of looking at things. Of course, the transfers happen all the time out of emergency rooms, so that's where it gets confusing. Well, if you don't have the services it's perfectly acceptable to transfer. But the law, several years later, it got much more specific. Of course, they changed things and they realized, okay, we weren't specific enough. And they really have some specific parameters around when you can transfer a patient. So as an example, if we were to get a walk-in trauma, or at Sequoia we don't have pediatric services. So we can do really great basic pediatric care. We have orthopedists that can come in and they can set an arm, but if the child has to go to the operating room for that injury, or you have a trauma, or we have a head bleed and we don't have neurosurgery and we need some more sophisticated, then we find an accepting physician at another facility. Typically we often go to Stanford because that's the close trauma center for us, and we do tend to ship out a lot of trauma and peds to them. We find an accepting physician, we make sure there's a bed, we fill out 2 pages of paperwork that I have to audit every week to make sure that every, I is crossed and I is dotted and T is crossed. We have to make sure it's all there because CMS can come and audit us and see if we're doing it all right. Because one fine for EMTALA is $50,000. So if April were to come up and I were to say something to April like, wow, we're really busy today, April, we're probably not going to get to see you. You probably want to go somewhere else. That could be construed as an EMTALA violation because I'm basically saying I'm denying you care. So that was a huge change in practice for emergency rooms. Really, really different. And now, and it's a little bit what I think has added to the fact that people kind of come for primary care because we can't deny you. So a medical screening examination has to occur, and it typically has to happen. There is some situations where a registered nurse can do it, but typically it has to be a nurse practitioner, a PA, or a physician, a PA being a physician's assistant. And some basic stuff has to be followed. They have to make sure you don't have an emergency medical condition. So sometimes you say, oh, well, if you came in with a paper cut, of course you don't have an emergency medical condition. Well, now the federal government's involved, so let's really be careful about, we actually have to get your history and physical. Do you have diabetes? Did you cut it on paper that you just dropped into a MRSA-filled, pool? Who knows? You've got to ask all these questions because it could be, you have to make sure that there is no emergency medical condition. Once that occurs, though, most places just treat you, right? I mean, we've already gone through the trouble. We've triaged you. A doctor or a PA or nurse practitioner has seen you. At this point, we may as well write you the script, right? Okay, you're here for cough and cold. Let me give you some cough medicine and move on. The other thing that the law no longer allows us to do, and it's very insistent, is that you must get that medical screening exam before I can ask you anything about insurance. So a lot of times people are really used to kind of handing the insurance card when they go to the doctor's office. We can't do that. So it's part of the training that I give to my staff on a regular basis is if they hand you the insurance card, you need to say, no, I don't need that right now. Do you have, if somebody has a really difficult to spell name, we'll sometimes ask, do you have ID or something that we can see? But we really try to be very careful. We don't want to look at insurance cards. This was a really great example of a complaint I got from a patient. So we have a main emergency room and then we have an overflow for when we get really busy. We have this extra room that has 4 stretchers in it. It's not the prettiest room. It tends to be the dumping ground for extra wheelchairs, bits and pieces of broken things, and no matter what we do to clean it out, it kind of becomes a mess. So we had a patient come in, put them in a regular room, got examined by the physician. So now it's clear to go in and get the insurance information. We get the insurance information, and then a couple more really sick people come in. And this person's not that sick, and the doc says, yeah, go ahead and put him in the overflow room in room 2, sure, no problem. So I just have to run a few tests, he can hang out there. Well, in the patient's mind, what happened was, you saw I had no insurance, because the registrar came in and asked about insurance, and then you moved me to a closet. So that was pretty brutal. And how do you change that perception? And had that person wanted to, they could have called and cited us for, potentially for an EMTALA violation. They probably wouldn't have gotten anywhere, but that's not the point. It's still kind of a pain to have them come out and look at that. So, I mean, that's when you think about, wow, I have no insurance and you stick me in there. And I didn't watch the whole movie, I'll admit, but I've seen the beginning of it. And that is a lot of the perception of people. They're waiting around, they don't have insurance, so I'm treated poorly. So EMTALA really changed a lot for a lot of emergency rooms, really changed the way we practice. And then the next sort of up and coming question that I have is, what will healthcare reform and the Affordable Care Act, what will that do to emergency medicine? And we really don't have a great idea of the impact of that at this point. We've had people come in already and saying, yeah, I bought insurance on the exchange. I'm covered. I've got Covered California. Do you have your card? Nope. Do you have your number? Nope. I tried to call and get it, couldn't get it. So there's a lot, the system is young. And there's just a lot of confusion. I've had people come in on January 2nd say, okay, well, I'm covered now, right? Well, did you go on the exchange and purchase? No. So there's a lot of confusion. There's a lot of things going on, and people coming expecting services that maybe we don't provide or can't provide them. Definitely using the ER as a primary care is very normal. It was interesting. I want to say 6 or 8 months ago, there was an article that somebody wrote saying that in fact, this new insurance, Covered California, all of that, off the exchange, that's going to lessen the impact on ERs. And I was just like, really, who did that study? Because I'm not sure how it's going to lessen it. Because think about it, if you've got people, a bulk of the people that are being covered are people that have not been covered in a long time, or perhaps young people that have never had coverage, so they don't have a primary care physician. You add that to the fact that we have less and less primary care physicians out there. Where will they go? They're sick. And by the way, we'll launch it January 1st, which makes sense. All new insurance starts January 1st, which is in the middle of flu season. So where are people going to go? They're going to go to the emergency room, and they're going to be inundated. And in fact, our numbers have been up. If people had their cards and we were able to get that, I might have been able to run some numbers to see what that impact is, but I'm not able to get that because most people that have come don't have their insurance cards yet. So we'll kind of find more out about that later.